a quick introduction to this webinar. This is a webinar on practical HIPAA compliance for ABA, why a manual is not enough, why process matters, and why proof matters. So this is, from all the webinars we've done, this is probably the most tedious and least exciting, because there's no rocket science over here, nothing fantastic, no fantastic corners of light that I will reveal over here. It's just basic drilling on what it means to be compliant. And there may be some repetition. We'll try to go through the slides quickly because I think it's more important to get a feel rather than to actually mark down all the details that we discuss. Now, you'll notice the design. It looks like something dripped all over the floor. That's very intentional because that's really what happens with HIPAA. People don't understand all the leaks that they have and the mess that they create on the floor by not taking care of HIPAA properly. So let's go to our disclaimer. This presentation provides general information regarding HIPAA compliance and is not intended to constitute legal advice or a substitute for legal counsel. Compliance requirements vary by state and specific business operations. You should speak to a qualified legal counsel to address your specific situation and regulatory obligations. Okay, this will really, I don't even know if we need a disclaimer for this webinar because there's no real legal talk over here. This is really for a compliance officer, for an ABA owner to understand practically what HIPAA means and how you deal with HIPAA. So the reason why we're having this conversation is because many clinics and clinic operators that I speak to think that HIPAA means a manual on the shelf, a checklist somewhere, and a quiet assumption that HIPAA is handled. It's usually not. Many clinics buy paperwork and call it compliance. They buy a HIPAA package, they get a manual, they have all their forms signed, they have a folder, and they think, okay, we're done with HIPAA. The problem is that HIPAA is not managed. HIPAA is very up to date. It's not something that rests in cobwebs. The ABA therapy setting is very dynamic and things are happening and somebody has to have their pulse on the situation. And compliance is really pretty much a day-to-day activity, depending on how big your clinic is. So as we said, the manual is not a compliance program. What is a compliance program? You need to train staff, you need to review access. Now, every piece of software, every piece of hardware has to be controlled, and this needs to be monitored and documented. So, and you every now and then need to review that access. It's not enough to do it once, but it has to be continuously monitored. If there's an incident, you need to investigate the incident, and you need to manage vendors. So, for example, we'll talk about this more later. You are using software and storage and all kinds of hardware and software from outside vendors, and your information is stored over there, which means you just violated HIPAA. And there are ways that, as you probably know, there are ways that you manage that process and stay within line with HIPAA. And of course, there's document follow-through. So HIPAA, as we said, is very operational. It's not static, it's very dynamic. There's a governance to it, which we'll see. There's training, there's risk analysis and risk management, access control and monitoring, incident response, vendor oversight, and documentation. So the paperwork is one input, and the program is the real work behind the HIPAA. So what does a real HIPAA program require? First thing, it needs a compliance lead and a security lead, which means that every ABA organization, it does make a difference if you're a 2-person organization or a 200-person organization. The rules require that you have a compliance officer and you have a security officer. Now, it doesn't say that these have to be full-time paid individuals. It doesn't say that they have to be dedicated. The CEO can wear all 3 hats if that's the type of setup that you have. But it's important to understand that there are 3 roles. It's not like, okay, I'll just sign as the compliance lead and the security lead and move on. There has to be a hat that you put on that makes you the compliance officer right now. And you look at the organization from a compliance standpoint. You need to put on your hat when you're the security officer, and you need to look at the things and do the job that a real security officer has to do. You need to have written policies, which again, we think most people have. The problem is that even the written policies, every policy, the manual has typical manual can have 30 policies. You have to read them and you have to sign them. So every policy is signed by the CEO, the compliance lead, and the security lead. And these manuals are not just to take and put in the folder, but they have to be read and signed. Training, you need to continuously educate your staff. You need to have a risk analysis, which means you have to understand the organization very well, every part of it. If it's an office, you have to understand the office, where people come in and out, where people can actually open up books with private information. And all this has to be mapped and monitored. And then you have to have your risk management, where you're managing what happens and what can possibly go wrong and how you're mitigating those possibilities. You need access oversight, which means that all your systems, doors have to be locked, passwords on computers. Every software system has to have multi-factor and encryption. That's called access oversight, where access is not free to anybody and it's locked up. All the information is locked and stored underneath layers of security. And you need incident handling. So incidents happen. Now, I want to make one very important note over here about incident handling. People are scared to report incidences, and very often legal counsel should be brought in. Compliance officers should have an idea what needs to be brought to legal counsel. But they really want you to report the incidences. It doesn't mean that you will be punished. Typically, you won't be punished. But what happens is that they want to see that you have processes in place. So if you have no processes in place, you probably don't want to report any incidences. Often it's not up to you. Often it could be a whistleblower or somebody else who's going to report it. But the first thing that every breach, the first investigation from the auditors by every breach will be, let me see your policies. Let me see your risk analysis. The policy itself, every policy that every ABA therapy company has to have, which they may know what's inside or may not know, has lists. There's at least 6 or 7, you can call it spreadsheets, you can call it checklists, whatever it is, that have to be available, that you are monitoring things. And we'll touch on a lot of those today. If you get audited and they ask you to produce those and you say, well, I don't have that, you're already in trouble, no matter how big or small the incident was. And if you do have your ship in order and there was a breach, so that means you're trying your best. And if you're trying your best, usually, depending on what happened, it will be, and it's handled, you'll see it has to be handled the proper way, then there won't be any penalty. And remember, the penalties for breaches are very, very high. It could be $50,000 for an incident. So you don't want to be incriminated on something, and certainly to show that you have handled a HIPAA very lackadaisically. So let's get back to the security officer and the compliance officer. Say it's the CEO and they just are the compliance and security officer in name. That's not going to work, because someone has to own it, someone has to track it, somebody has to follow up, somebody has to escalate. If there's an incident, it has to be escalated. So if it's the CEO, maybe escalated to an attorney to see how to deal with it. And last, and very importantly, it has to be enforced. If it's not enforced, then you don't really have a policy. And this is where a lot of the programs break, because there is no somebody. We just designate the operations officer or a BCBA and we say, okay, you're going to handle compliance. They don't understand what it is and they're not doing real compliance. So it's important that the compliance officer understand their role and take it seriously. So we talked about how there are many parts of HIPAA, and a typical risk center, you have at least 8 places where you're tracking risk. It could be the control and the evidence, the risk register, the vendors, the incidences, the PHI data flows, and we'll talk about that more, patient rights, training and workforce, and then your policies. So again, this is, if you have a real system set up, this is live. You'll see that parts are green, parts are red, and you'll get notices that what has to be done, what's not taken care of. And that's what real compliance looks like. So we talked about a lot about privacy, but let's drill down to what exactly we're protecting and and how we're protecting it. So the idea of privacy is protected health information that nobody is entitled to know anybody else's health information, and that's a federal law. So what constitutes health information, or at least protected health information? So you have clinical documentation, which are assessments and treatment plans. You have session notes and behavioral data. You have supervision records, and you have authorizations, because let's take an authorization. Authorization says so-and-so is entitled to treatment. Now, that is a revelation about that person and his health information. So that has to be protected. Even financial data, claims and billing data also has to be protected. Somebody's paying for health services, that is a revelation about their health condition. In ABA, any record that linked to these details to a patient identifier constitute protected health information. So the question is, what is a personal identifier in ABA? And it's not just a name. There's many parts to it that are called identifiers, even if you don't actually have the person's name. It could be a name, geographic subdivisions, dates of birth, telephone numbers, fax numbers, email addresses, social security numbers, medical record numbers, health plan numbers, account numbers, certificate license numbers. All these things, once they're linked to the health of a person, are protected health information, and they will be breaches if they're not protected properly. Now, where are the touch points in an ABA where the protected health information is stored? So you have your EMR and data platforms, which that everybody realizes, because that's the guts of the heart of the system where the information is. You even have scheduling and billing systems. People think that that's not called protected health information, but as we saw, any scheduling or billing of somebody of a session is called protected health information. You have email and cloud storage. So if you have third-party storage, that means that that's being stored, and you don't know if that's secure, because all these systems that are third-party vendors, you are responsible for HIPAA as well, and we'll see how you take care of that. Every employee's phone, tablet, and laptop, certainly the ones that belong to the clinic, and even the ones that are private, if they're using it to transmit information, they become HIPAA touch points. Papers, files, cars, bags. If somebody travels with a briefcase in their car, then their car becomes a HIPAA risk. If it's in their bag, wherever they go, that bag becomes a HIPAA risk. So you need to understand the vast and extensive reach of HIPAA. So who does this apply to? This applies to just about everybody that works in the ABA. And they could be BCBAs, RBTs, supervisors, schedulers, even billers, admin, even contractors, and vendors as well. The clinic touches it, operations touches it, billings touches it, even IT touches it. So if you have an IT company that works with you and they have access to your systems, that means that they need to understand what HIPAA is, and they need to guarantee to protect the information. So we talked a lot about policies, and you have to have policies in place. But there's more than that. There's processes and documentation, and that's what saves you on audit day, showing the processes and showing the documentation. So we can call this the 4 Ps of HIPAA. You need to have the policies, the paper, the people, which means the owners, all the people that create HIPAA information, the PHI, and the people responsible for it. You have the process, which is the way the ABA operates, if they are security aware or they're not. And that, again, is very critical. If it's a side issue for them, then they will breach it all the time. If it becomes sort of an overarching importance, and everybody's trained and sensitive to the fact that there needs to be privacy, then the clinic will look different from a HIPAA standpoint. And all that is very nice, but at the end of the day, you can tell the auditors how careful you are, but if you don't have proof of that, then it's as if you actually didn't protect it. So for example, if you were to get audited, if you had this nice folder that gave you all the information from all the potential risks and all the spreadsheets that you had to use, and you sent it to them in one package, they would be thoroughly impressed, and probably the problem, the audit, would disappear very quickly. So let's talk a little bit about risk analysis and what the documentation means. So the first thing you have to document is what systems hold PHI, which requires the ABA to have a list of systems that hold the ABI. And there should be, technically, a spreadsheet with every system that you have. And that system could be hardware, it can be software, it can be shelves in the office, it could be drawers. Now, are those drawers locked? Are they not locked? How PHI moves. So a lot of times they don't live in silos, but the PHI flows from one system to the other. Either there could be an API from one software to the other, or you can have files that the receptionist brings to the BCBA or the RBT. So we need to watch and make sure and have a process for how that file moves from the receptionist desk to the room where the therapy will be applied. You have to monitor, and again, this needs a spreadsheet, right? You need a spreadsheet to say what can go wrong. When this happens, when we're moving a folder, what are the possibilities that can go wrong? Maybe they get a phone call and put it on the desk. Maybe they forget that it's there. All these things have to actually be rated and marked what the potential risks are. Where are the weak points? How severe the risk is. Now, if you have to assess if any of these things, now again, this is a flow, right? What can go wrong, where the weak points are, and how severe the risk is. If so and such happens, what's the potential liability? What potentially can happen? And then you need to have a plan that says what gets fixed first. So again, this is what a system might look like. Where does PHI live? How does it move? Whether it's covered, and everything should be documented and encrypted very well. So just again, to recap, every flow is fully described. You need source and destination. You need the PHI type. What is it? What is this PHI? Every PHI has to be labeled. Is this treatment? Is this a session? What is this? The transmission method, the encryption in transit, that means the protection as it's transiting, and the reviewed and dated. So if two systems are talking to each other, is it transmitting from one to the other openly, or is it encrypted and only unencrypted when it gets to the other side? And then you need a compliance check. Is it reviewed and dated? So where do ABA clinics actually run into trouble? So the first thing is shared logins. You got one login that everybody uses. Now, what happens is that one of the things, and this is very crucial, when it comes to PHI, one is that everybody should only be able to look at the information that's. So we don't give every RBT, every BCBA, and every admin the same access. Everybody should only be seeing the information that's relevant to their job and not one shred of information more than that. So when you have shared logins, obviously everybody gets open access to all of them, and that is a HIPAA breach. If you have unencrypted device, if you have loose permissions, offboarding, what happens when a RBT or a BCA leaves? How quickly do you erase their accounts, right? They no longer are allowed access to any of the client's information. So if they were using their own smartphone or a company smartphone, how quickly did you, if they had their own login to your EMR, how quickly did you erase their account? So it's very important. Offboarding has to be done within really, that same day for sure, and as fast as possible. That's what they want to see. They don't want to see a BCBA walk out the door and have information with them. By the time they walk out the door, they should have nothing on them. Staff-to-staff PHI over text. People like to talk about things over text, staff members that are friendly about different sessions, and that's very dangerous. Wrong email recipient. Sometimes you send the email to the wrong person. That's a HIPAA breach because now you just send PHI to the wrong person. If you have unreviewed vendors, have you checked all your vendors and made sure that they are HIPAA compliant? And it's not only HIPAA compliant, I'm not sure if we're going to touch on this soon, but there's something called the BAA. There's a business associate agreement, which basically says that if we're going to use your storage or your email or whatever services that applies, that has our protected health information in it, that you agree that you are HIPAA compliant and you will protect the information that our information that's in your system the same way we would. And that's most of the systems obviously have it. A lot of the email systems have it. All the big vendors, even if they're not specifically ABA clinics, they understand that healthcare is a big business, and they all have, depending on if you have a lot of the free services, storage or whatever it is, you can't get a BAA, but because they know that you're using it for professional reasons, so they only have BAA for the paid clients or for the high, not even all the paid clients, but sometimes only for a higher tier client. So yes, it's going to cost you money to have BAAs set up. So this is what we said before. You have to measure a few things, and it's sort of a matrix. What's the likelihood that this process will expose HIPAA? It will expose PHI. And if there is a high likelihood, what's the impact that will have? So everything's a trade-off. A low likelihood with a very big impact is dangerous. A high likelihood with a lower impact could be dangerous as well. You need to know who the owner is, who is managing this process. Mitigation, what are you doing to mitigate this exposure? And the target date. When do you plan on taking care of this mitigation? And then obviously to sign off what it looks like when it's done. So we talked about the mitigation plan, and that's the risk management aspect of it. So you have an owner. That owner, it could be the compliance officer, is in charge of exposing the HIPAA and then managing it. So you need to have the mitigation plan, a due date, a status. Where is it holding all the time? You should be able to push a button and know, or have a spreadsheet that says, today, this risk, what is the status of this risk? And then you need proof of action. So again, I think this is redundant, but you should have your spreadsheet that has the open risks, the date, and the status of it. And you should have an overall view of what's going on. A good compliance manager should know at all times the overall health of their HIPAA compliance. So now we have a compliance officer, let's say, that understands HIPAA and he's doing a great job. What about the actual employees? One of the rules of HIPAA is that everybody needs to be trained. Not only do they need to be trained, but they should be signing attestations, which should be stored. And you should be able to show the auditors that if there's a breach, right? So they say, why didn't you train your people? Okay, we trained them. We have continuous training. We have dates of their training, what the training consisted of, and we have attestations from every employee that they actually underwent the training. Now, we can't control people, but we can try to do things that will help create certain environments and certain behaviors that will protect the PHI, which is the best we can do, and that's understood. So the question, what does staff have to understand? Staff has to know, first of all, what is PHI? They may think like, oh, I sent a picture of a kid without any information and I posted it on Instagram. What's the problem? Okay, that's a face, and that's a HIPAA violation, and a very big one. So they need to know exactly what are HIPAA violations and what aren't HIPAA violations. They need to know what not to share. Very importantly, they need to know how to report an incident. They need to understand that it has to be reported right away. And if there was a system in place to report it, that would be excellent. What to do after the mistake. So really, the compliance officer should get this report right away and instruct the employee or the staff member what to do. But they themselves should understand that a mistake happened and to mitigate the mistake by themselves as soon as possible. And they should know who to tell. It should be very clear to them in their training who they report any HIPAA violations to. It could be to their supervisor. If it's an RBT, it could be to the compliance officer, whatever it is, but there should be some sort of escalation and who to go to. And how fast to act. Is it okay to wait till tomorrow morning if something happens 9 o'clock at night? Or is it an emergency that you need to wake up the compliance officer at midnight because you realized you had a breach? We touched on this before. Access control is daily HIPAA. So you have role-based access, depending on who you are, what your role is. That's what type of access you should have to all the systems. So for example, even a BCBA may not need access to the billing. Billing certainly doesn't need to see treatment or maybe they do because they have to make sure which claims are valid and which aren't. But whatever it is, that should be mapped, and there should be a clear role-based access. These are the people that get to see X, and these are the people that get to see Y. There should be unique user IDs, no casual password sharing, periodic access reviews. You can't, this is not set it and forget it. You need to continuously review this, and there needs to be what we spoke about before, fast offboarding. So every 90 days, you should ask yourself, were there new hires over the past 90 days? And did we train them? Did we give them the proper access? What did we do? Were there role changes? What happens when RBT becomes a BCBA or BCBA becomes a clinical director? Things change. Or somebody was once a clinical director and left and became just a BCBA. Do they still have access to all the information that a clinical director would have? Departures, who left, and have they been erased from the system or they've been denied access to the system? Contractor access. Somebody comes in to fix your system and you give them access. Was that timed? Did you open it up for them and forget to close it? Or did you make sure that they only got to see what they see and for only the time that they needed? So we said that you should have all your audit logs with anything related to PHI that was done, any breaches, any changes. Really, this log should control every operation or every documentation of any HIPAA action that the compliance officer or security officer takes, or anybody. There should be a list of the complaints. It should be a list of reading the complaint. There should be a list of investigating. Each one should be an entry. It should be a list of mitigating, right? Everything, there should be a list of a new, the log should have a new software system was used. An old software system was stopped. We had storage, we terminated the contract, and we made sure that we erased everything in the old storage. So that's what these review logs should do. So you should be able to see who accessed what, right? That also is very important. You have a list of every access into the system, who was looking at it, and what their permissions were. When did they access it? If you see somebody 2 o'clock in the morning taking doing a lot of snooping around the MR, that's something to be concerned with. Whether it fit the role. Did what they were looking at, was there something amiss? Is that something they should be looking at or not? Whether follow-up happened. So red flags, you have access to the wrong patient. Somebody has access to a patient that's not theirs, and they don't really need access to that. Odd hour activities, large record pulls, terminated user activity, repeated failed logins. That means that somebody's actually trying to breach the system. So your risk does not end with your staff. So let's talk about some of the outside vendors who pose a risk to the PHI. You can have a billings company. You can have an IT provider. You can have cloud tools. You can have telehealth tools. If you are doing, this is something nobody would think about. If you're doing telehealth, so you're thinking that, okay, we're just using Zoom or whatever you're using, but that company is watching the session. So do you have an agreement with them? Storage vendors and even consultants. If you have a business consultant coming in and trying to help you figure out the business, do they have access to PHI? And how much of it? Do they need to know people's names? Probably not. It's enough probably to see the client ID, so they shouldn't be given information that they don't actually need. So for all these people, for all these groups and companies, organizations, you need to have a business associate agreement, and they're not just templates, they're things that really need to be signed. You need to identify the vendor, classify it, get an agreement, track it, and monitor it, because they expire. Is somebody watching that the BA didn't expire? If the BA expired, and you're continuing to use that vendor, that means that your PHI was exposed, and that's a HIPAA breach. So anytime we have around with them folders, now I know this is a stretch, but if a BCBA takes home a file, that BCBA really has to put it on the lock and key. They can't leave it on their dining room table. People come in, people come out. There are other people that live in the house. Nobody's allowed to see that. That's a HIPAA breach. Now, again, is anybody going to catch that? Is anybody going to do anything about that? No, but that's the HIPAA law, and it's something to understand. Even if you don't see it as an audit risk, it's still a HIPAA breach, And that, again, it becomes an attitude in the company how we deal with HIPAA. So is it just to get away with an audit? Is it because we really care about privacy? And if you have the stance that we care about privacy, then again, the HIPAA will certainly go a lot smoother and cause you a lot less aggravation. So you have to manage inventory, which means you always have to know the inventory of all your hardware and software. You need to know every tablet, every computer, everything, every phone that has HIPAA on it, has PHI on it. You need to manage passwords. You need to manage the encryption. You need to manage transport controls, reuse controls, and disposal when it's time to get rid of it, that something could be wiped, let's say remotely, just from a console, from a dashboard. So here's incidences that are more common than clinics admit. So you have a staff member phone is taken from a car overnight. A staff member has their phone, they leave it in the car, and the car's stolen. You now have a HIPAA breach. Technically, this has to be reported. And the scheduling app is open. Now, again, the question is, was anything open? Is there a password? Is there multi-factor authentication? Can you see if somebody went into the session? These are all things that the compliance officer has to know. And a good program will be good because just by the mere fact that a phone is taken doesn't mean that there was any HIPAA breach. And was it reported 2 days later by text, or was it reported right away? So by the time the clinic realizes what happened, the device status is unclear, the timeline is unclear, nobody documented the initial report, and nobody knows if this is a breach. This is not a rare case. These are things that happen all the time in ABA clinics, and nobody even thinks about the HIPAA breach. So let's talk a little bit about a real incident response. So the compliance officer should receive the report, should document it, and the report can be, if it's a online form that every staff member could fill out, that's fantastic, because it gives shape. They don't just write, people don't usually write very detailed, or they usually skip most of the details that you need. If you have a form, then it can be documented with all the documentation that's necessary, and it will show that itself, that you have that form, shows that HIPAA is being taken care of. So the compliance officer gets this form, he assesses the scope of it, he first of all figures out if it's contained or not, how far reaching that breach could be, investigates what happened, determines whether PHI is involved. So we have a breach, but was there a real PHI involved? And then you assess the breach risk under the 4-factor test, which we'll get to in a minute. What the officer does is implements corrective action and keeps the record. And that's a breach, and it's in the system, and it shows the seriousness of the compliance department, that it was taken full cycle from breach to resolve, until being resolved. What is the 4-factor breach risk assessment overview? First is, what is the nature of the PHI? So we said that there are many identifiers, but if there's no name, it's a phone number or something like that, or something that's less of a good identifier. So again, the risk is not as high. Who the recipient is, who used the PHI, and to whom the disclosure was made. So who has it? If it's a car thief, okay, we don't really worry that much, because they're probably not really interested in anybody's health information. They just wanted a car. And they'll probably dispose the phone or wipe it or do whatever they do, but this is not a high risk for a HIPAA breach. Acquisition. Did they actually get the PHI? Yeah, sure. Anybody can crack the code of the phone and get in, but again, it's highly unlikely that they will. And the mitigation. To the extent, what's the risk that the PHI mitigation is going to be mitigated? So is the phone, what are you going to do with that phone? How are you going to deal with that phone? That's all part of the 4-factor breach risk assessment. Now, we gave an example of something that was really not much of a threat, but obviously if a computer is left open in the reception office with treatment notice, and you got a full office with kids jumping all over the place, then that becomes a bigger risk. And every risk has its own 4 tests, and the composite of these 4 tests decide how bad the breach is. So part of HIPAA requires that you need to take corrective action and sanctions. It means when there's a breach, you have to do something about it. So you have to figure out what must change. Something must change. What failed, and if something failed, you have to figure out how to improve that. Who was involved? You have to figure out who the people involved were and what their was it innocent? Was it negligent? Was it because they weren't trained? And you need to figure out what their complicity is in this whole story. What gets fixed? What gets retrained? What access changes? So you may understand that the access is too easy to breach, and passwords may need to be changed. Even the way to protect it might have to be changed. These are all things that have to be taken into consideration. Now, you need to have sanctions. That's one of the things that HIPAA requires. That means that if somebody does something, it doesn't go forgiven. It's not forgiven and forgotten. Something has to be done. The question is what? So again, that's a big, that depends very much on what the breach was and how negligent the person was. Sometimes it could be a verbal warning. Sometimes it could be a written warning. Now, sometimes it could be somebody who's continuously negligent and they have breach after breach. So sometimes you could have mandatory training. You understand that this person just doesn't understand what HIPAA is all about, and it's time for a retraining. And then you would document that they were retrained. The person would attest. And again, that goes into the audit log like everything else. Sometimes it will be a suspension of access. And sometimes if the breach is very bad and continuous and it's done wantonly, let's say somebody continuously can't control themselves from posting on their WhatsApp status cute pictures of their sessions, then sometimes termination is warranted. And again, you may want to be nice, but when termination is warranted and nothing else helps and you do not terminate, that will make the ABA clinic responsible and you can get fined. So what's the file you want after an incident? You want an incident report, you want an investigation record, you want containment steps, you want the breach assessment, the sanctions decisions, if applicable, the retraining record, the corrective action log, the policy or access changes, the final resolution record. Every record you should not have any open records. Every record should be resolved somehow or another in an appropriate manner. And then you want the preemptive improvements. It's nice that you resolve this one, but part of it has to be to make sure that it doesn't happen again, and that's part of this record. So again, we talked a lot about the audit logs, and this is what an audit log would look like. Everything goes into it. Everything done, every move made in compliance should be in the audit log. There should be training records, risk analysis, risk register, access reviews, incident logs, corrective action records, breach assessment, vendor agreements, and retention records. And this all neatly can go to an auditor in bulk to show, that, look, we're constantly monitoring, we're constantly logging, and of course, the individual areas by itself. So as we said, and I hope it's clear by now, HIPAA is not a once a year thing. It's not a once in a lifetime thing. It's a recurring function. It's not a project that has to be done every now and then. There's weekly tasks, which could be onboarding, offboarding, access changes, incident reviews. Then there's monthly tasks, which means open risks, training completion, right? Training doesn't have to be done very often, but it has to be done often enough. Vendor status, you have to keep up with all the vendors. And then there's things that aren't on a timely basis. And I just want to tell you that in the compliance manual, most compliance manuals, and I'm not sure exactly what the law is and what's just standard, but it actually says how often things have to be reviewed, whether it's the risk access, the PHI flows. These things by law have to be reviewed. I'm not sure, again, what the timing is, but all that is in the manual. And the first thing that the auditor will ask for is the manual. And then the auditor will hold you to whatever the manual says. You can have all the excuses in the world, but if you could say, look, I thought, training once every 2 years was enough. But if the manual says that employees need to be trained every 6 months, every 3 months, every once a year, then you are held up to whatever the manual said. And then there are things that aren't on a timely basis. There are things that are triggered. So if a new software vendor comes in, a new location is open, if you start hiring rapidly, or there's a security event, or there's records request, so that all that would require review. So this is what we said before. If you have a HIPAA manual, it obligates you, open it, read it, and train according to the manual. So you have your own policies almost certainly require an annual risk analysis, an annual policy and procedure review. So you may have gotten your first policy set, your first manual, but the manual is made up of, like we said, a bunch of policies. The policies need to be reviewed because theoretically that first manual was custom made for your organization. And things change in the organization. It was made for what you thought the organization was going to look like. But after a year, the organization often doesn't look like that. Certainly if you're growing, it doesn't look like that anymore. And the policies and procedures have to be reviewed to see if they're appropriate for what the new clinic looks like this year. Because your clinic last year is not your clinic this year. You need annual workforce training, periodic access reviews. So every now and then you have to check the audit logs, see who's going into the system, see what the audits are turning up, and update after any material change. And the event-driven review is also required if there's a new EMR or data platform, a new vendor touching the PHI, new location or service line, rapid hiring layoffs or remote shifts, security incident or breach, parent complaint or records request. As soon as that happens, you need to make sure that everything's done above board. So HIPAA doesn't set the calendar, your manual does, and regulators will hold you to your own commitments. So now we come to the closing, and this is the truth time. Everybody has to ask themselves some hard questions. When was the last documented review? When was the last time you did a risk analysis? When, honestly, was the last time you reviewed your policies? When was the last time you checked all the accesses? When was the last time you reviewed your vendors and made sure that they had the BAA agreements up to date? And when was the last time you trained? Training is something that nobody likes. Everybody considers it a waste of time. But when was the last time you trained your employees? And do you have the proper attestation and proof for all these things that happen? If you're just going to review a policy, look through it and say, yeah, I'm good with that. Even if you're not going to change it, you should definitely document and say the policy was reviewed on this and this date by this and this person, and the findings were that all the policies are in order. Each policy one at a time. This was in order, that was in order, everyone was in order, and therefore no changes were made. That itself is very important. What are the 10 most common breakdowns in an ABA clinic? First is there's no real owner. Nobody's owning compliance. The second is there's no true risk analysis. Nobody really figured out where the risks are. There's no risk register. Now, the risk register, that's the documented risk analysis. Weak training. There isn't any real training other than, one time, okay, read the manual, tell us that you read it. Overbroad access, where people are getting access to more things than they need. No meaningful monitoring. Nobody's monitoring any of these things. Weak device controls. People are coming in with their private devices and sending emails and talking to clients with it. Informal incident handling. Somebody walks into the office, says, yeah, I did this and that. Okay, yeah, it's fine. Nothing happened. It's okay. Let's just move on. Weak vendor controls, and of course, poor documentation, because if you have no other problem other than poor documentation, then you have every single other problem. So 10 honest questions to ask yourself. And you probably know these questions by now. Do you know who owns HIPAA in your clinic? Do you have a current risk analysis? Do you track open risks? Do you review access? Do you track incidences? Do you know every vendor touching PHI? Do you have BAAs in place? Do you review logs? Do you have training records? Could you produce documentation quickly? Sort of is the answer that should worry you. So sort of trained is not actually trained. Sort of reviewed is not actually reviewed. Sort of tracked is not actually tracked. Same with documented, assigned, and monitored. So if you sort of did all these things, you definitely didn't document them, because we don't document sort ofs. And if we do, then it's very clear that it was sort of and not really worth the paper that it's written on. So one more time, the policies may help you start, but process and documentation save you an audit day. Review is what keeps it real. So if you want an action plan going forward, what can you do? First thing, to, if you feel, if this webinar was a waste of your time, then hats off to you and fantastic. I'm happy to hear that. But if this was any sort of revelation or eye-opening webinar for you, then the first thing you need to do is to assign an owner, one person accountable, and naming it in writing. There should be a document that says that so-and-so was appointed compliance officer, and then another document that says so-and-so was appointed security officer. These are like the basics of the basics that you would have to produce in an audit. The next thing you should do is do a real risk analysis, not a checklist, a documented look at where PHI lives, how it moves, and where it's exposed. They want to see the PHI flow, is the terminology that they use. And the third thing you should do is start a risk register. Every finding gets an owner, a date, and proof of action. Whether you do this internally, bring in outside help, or use a platform is the second question. Do these three first, and you'll be on your way. So the better question, to sum it all up, is stop asking whether you have a manual and start asking who is managing HIPAA, how often, using what process, and with what proof. These are the questions that decide or show whether you have a real HIPAA program in place or not. Because HIPAA compliance is not a folder, it's a function, and it becomes most visible on the worst day. Thanks for joining the webinar, and the clinic that understands the difference are the clinics that are building a real program. And good luck to all of you on your compliance, on your growth, and on your ABA clinic. If anybody has any questions or wants to contact me, you can reach out to me at Tzvi Weiser, Tweiser, at nucofilings.com, nucofilings.com. Or you can reach out to me on, you can easily find me on LinkedIn, and you can DM me. You can look for Tzvi LLC Weiser. I don't think they'll show you 3 or 4 of those. I think I'm the only one. So good luck, and I'd love to hear from you, especially if you have any questions. I'd love to help. So feel free to reach out. And again, thanks for joining. Appreciate it.